Welcome everyone. Thanks for joining us this evening. I'm Jana and I'm here with Dr. Sollenberger. I'm going to be the moderator this evening. I wanted to point out a feature of the webinar. There is a questions area, and so throughout the webinar, if you have any questions, you can chat those our way, and I'll make sure to read those at the end. Dr. Sollenberger has left about 10 minutes at the end for Q&A, so don't be shy and ask as many questions as you like. I'd like to pass it over to Dr. Sollenberger to get us started here.
All right, thanks, Jonna. My name is Eric Sollenberger, and basically, I appreciate y'all being here tonight, but I wanted to talk a little bit about glaucoma. For a lot of people, it's a scary word. It's often kind of a misunderstood disease process, and the treatments and things that are available, we'll run over that. So let's kind of start off, the evening with just sort of breaking down some terminology, getting some definitions. And so let's talk about actually what glaucoma is. And basically, it's a group of diseases where you have damage to the optic nerve, the part of the eye defined as this yellow square. And it typically happens in the setting of high pressure. And basically, that optic nerve is the cable that links your eye to your brain. And it allows you to process the image that your eyes see and basically give you vision. And without it, you can be blind. And so what happens if that gets damaged, if that cable becomes damaged enough, you begin to lose vision, and it typically causes vision loss from the periphery and works its way towards the center of your vision, which is one reason it can be basically such a kind of sneaky disease. And you've seen patients that have spinal cord damage that are maybe permanently wheelchair bound or permanently disabled, or stroke patients that have, permanent disability. Oftentimes, it's actually the rare exception for you to recover from any kind of nerve damage in the body. And with this in particular, is the same way. So once you lose vision from glaucoma or from this nerve damage, you can't recover it. So let's kind of dive in a little deeper. And yes, there's more than one type of glaucoma. The most common being what's called open angle. When most people think of glaucoma, this is the type that they're thinking of. Basically, you have a structure in the eye defined by the blue arrow here. And that's the ciliary body that produces fluid. And then the area called the angle, where the colored part and the white part of the eye meet, you have the yellow arrow pointing that out. That's the drain of the eye. And so in open angle glaucoma, you have an open drain, but it's slow flowing, and so fluid continues to be made inside the eye. Pressure builds up, and it damages the optic nerve. This one is the one we worry about most. This one tends to be the one that flies under the radar. Patients will lose a significant amount of vision without any other symptoms, no pain, anything, for years, kind of sort of unnoticed until you have advanced disease. The narrow angle type of glaucoma is the drain is kind of not totally shut off, but it's a little bit narrowed, and the same thing happens as you get reduced flow. In terms of closed angle glaucoma, basically that drain, the colored part of the eye, totally pushes up against the cornea, or the clear surface, and it completely blocks the outflow of fluid. This type of glaucoma is one of the few eye emergencies that we have, and basically this can cause a lot of pain, a lot of redness, and blurred vision in the eye. This type of glaucoma tends to not be very subtle. It definitely draws your attention. It can even make you nauseous, make you throw up, kind of trip to the emergency department because you know something is wrong. And then there's a fourth category. It's called low tension glaucoma, and it looks like open angle, but the pressure never kind of reaches above most people's threshold is 22. And so we see pressures maybe in the mid to high teens, and but we still see optic nerve damage. And so we think that low tension glaucoma is actually a totally different disease, but it just looks like glaucoma, and we treat it by lowering pressure even further, so we kind of lump it in with everything else. To kind of go a little further into the anatomy, can you all see my mouse? I don't know if you can, but where you see the red arrow above our logo there that says open angle, basically the cornea is the clear surface of the eye, and the iris sits behind it, and they should make an angle right where my palms are meeting, and that's where the fluid drains out. And there are some conditions that can cause that iris or that colored part of the eye to basically push forward into the cornea, and you can see there's no place for fluid to flow out. And so that's what actually causes angle closure episodes. So then, all right, let's say, okay, well, that's glaucoma. Those are the different types. Now let's talk about who gets it. Basically, risk factors are one of the biggest ones is age. As you age, glaucoma becomes more and more common. If you have a family member that's affected, you are 10 times more likely to have glaucoma yourself. Race does play a role in this. African Americans are more likely, on average, to have open angle glaucoma and to have advanced disease when diagnosed. And then those of East Asian descent are also more likely to have angle closure glaucoma. So race does play a role in here. Diabetics, for multiple reasons, end up having a higher prevalence of glaucoma. And then there's also a condition where the cataract in the eye grows so large that it kind of takes up too much space. And just like I was talking about that iris bulging forward, that cataract can cause that and cause your angle to close. There are a number of medications, you see them on TV all the time. Talk to your doctor if you have glaucoma before starting this medicine, all those warnings. 99% of those, if not more, are talking about angle closure glaucoma, which is overall fairly rare. However, long-term steroid use in any form, so nasal spray like Flonase, long-term steroids by mouth, multiple kind of steroid injections into joints and things like that, and steroid eye drops can all cause your pressure to go up slowly in more of an open angle form. And again, that's where damage is being done, but most people are symptomatic. So speaking of symptoms, what are the symptoms of glaucoma? What can you expect? And that's part of the issue. Glaucoma is called the thief of sight. It slowly steals your vision, typically, like we talked about, from kind of the outside in. And a lot of people, it's amazing that you don't notice it's happening until it's pretty advanced, until all you have is basically like looking through a tunnel, and you might bump into a wall or somebody, you get in a car wreck, and that kind of brings this, somebody kind of is in your blind spot, so to speak, except you have a large blind spot. So oftentimes that's when people will present with advanced disease. That is why annual testing with your eye care provider is important to check pressures and things like that. So in really advanced glaucoma where your pressure is very high, or in angle closure episodes, some people will have headaches. They will have eye pain, kind of sort of causing the headache. Their eyes will be red or their vision will be blurry, and they might even get kind of this rainbow effect with like headlights, taillights, streetlights, things like that. So, all right, say you decide to get checked. What can you expect during your exam? And basically, this is Dr. Stone. This is one of our providers. Most eye care physicians will check your pressure using a variety of devices. There are some electronic devices now, and we use one called Eye Care. And it's fantastic. It doesn't require any numbing drops. It's not the puff of air. Most people hate the puff of air. It's not painful, and it's fairly accurate. And if that screening tool shows that your pressure is slightly abnormal, there are other ways that your doctor can kind of really dial that in and get a more exact pressure. But you also should have a dilated eye exam or photos of the optic nerve during your annual eye screening. And together, those things will give you kind of a picture of, okay, maybe this person does have glaucoma, maybe they're on the cusp, or they definitely don't. And if you're on the cusp, or there's any suspicion, or if we think that you may have glaucoma, basically we'll order more testing. And when we talk about kind of more testing, there are a few different things that are sort of staples that we use. One of them is called the visual field testing. Some of you may be familiar with this. If you've ever taken one, you'll certainly remember it. It's a test where you have kind of a hemisphere in front of your face and little flashes of light flash at different intervals, and you click a button whenever you see it, and through that the machine can tell what you can see and what you can't. And so this black and white image is a visual field printout of somebody with glaucoma, and you can see the machine tries to kind of, it shows us what you're missing, what you can and can't see, and you can see under the letter B there that white patch represents about this much vision, and that is all that patient has left. So everything beyond that is basically completely dark. And that can be, people that get to this advanced degree of glaucoma are definitely functionally limited by that degree of vision loss. You can see under the letter A, the other eye, that's the right eye, is affected, but not quite as severely. They still have a little bit more vision loss or vision left. So that may be one test that your eye doctor orders. And then you'll see the color photograph or the color image. Basically, this is an amazing machine called an OCT, or optical coherence tomography. And this takes a matter of seconds, and it allows us to take a very, very fine detailed image of your optic nerve. And it will actually measure in microns, I mean, how thick the cells are, of how thick those nerve cells are and how healthy they are. And if the nerve cells start to thin out in a way that looks like glaucoma, this machine will flag it as these little red pie slices down towards the bottom of that image. There's also an additional test that your eye doctor may or may not do, depending on kind of what they find, is called gonioscopy. That's where we put a numbing drop into the eye, and we actually put a small lens onto the eye. And again, it doesn't hurt because your eye's numb, but it directly looks at that angle that I keep referring to see if it is narrow or maybe at risk of closing. So, okay, you go to your doctor and they say, hey, you might have some, or you do have some glaucoma. And most people think, oh my gosh, I know somebody that's gone blind from this. Does this mean I'll go blind? And the answer is almost certainly not. Basically, with modern screening, diagnosis, and treatment, there are still some people who do lose vision from glaucoma in a significant degree to where it affects their function, but the vast majority of people do not. We have so many medications, lasers, and surgeries to treat glaucoma, and we're so much better at picking up early disease than we used to be, that if you do have your annual eye screenings, it's very, very unlikely that this will go missed and that it would result in any vision loss. So say you are diagnosed with glaucoma and you want to know what the treatments are. Basically, you have three main options, but the goal of any or all of these is to reduce your eye pressure. We know that is the only thing that we know of that actually will slow the disease or even stop the progression of disease. And so when it comes to drops, a lot of people are familiar with eye drops. We basically have 5 medications or 5 classes of medications that we can use. Each one has their own side effects. Each one has their own, sort of interactions with the rest of the body, and some are more tolerable, some are less tolerable, some are once a day, twice a day, and 3 times a day. And so if you're having this discussion, a lot of times this is very individualized, and your eye doctor will likely make recommendations based on your individual situation. For example, one of our medications is not good in people who have asthma or COPD. You don't want to give somebody a 3-time-a-day drop if they just can't do it 3 times a day. So things like that, you kind of tailor it custom to the patient. When it comes to lasers, we have a few different types, and each one has its place. And these 3 lasers are not all used for the same types of glaucoma. So the SLT is called selective laser trabeculoplasty. What this is, it's one of the most kind of benign things that we offer as a procedure in ophthalmology. It's extremely safe and it's very effective. And there's new data out on it. The 6-year study of the best kind of randomized control trial that's been done with these lasers is showing that the laser groups are actually on average some of them are doing slightly better than the drops group. So it's changing the way that we practice. Basically what we do is we apply a light laser to the actual drain of the eye. If you imagine the drain as just a meshwork, what it does is it opens up that meshwork and lets more fluid flow out and brings your pressure down. This is reserved for open angle glaucoma. It works well for open angle glaucoma where the angle has quite a bit of pigment in it because the pigment actually absorbs that laser light a little bit better and we get a better response. The YAG laser. Some of you all who have had cataracts may be familiar with this. It's often a laser that we use after cataract surgery to help polish the scar tissue off the back of your implant. We also use this laser. We can actually make a small opening in the colored part of the eye to allow fluid to take a different path and help prevent angle closure attacks. So the YAG laser is not used for open angle, but for closed angle glaucoma. And then one that is not as common is the CPC diode laser. This is typically reserved for people with advanced glaucoma, people who are not great surgical candidates due to maybe other health conditions. And when it comes to surgery, basically, we now have these kind of minimally invasive, or they're called micro-invasive glaucoma surgeries, and they're a whole kind of category that's blossoming, and they're blossoming right now because patients heal quicker, the outcomes are excellent, and it's just sort of it's made these traditional glaucoma surgeries a little less. We're just doing less of them because we don't need to. And I mentioned cataract surgery. Cataract surgery alone has been shown to lower your pressure to some degree. If you are at risk for angle closure, cataract surgery is basically curative. In addition, some of these, if you happen to have cataracts and glaucoma, these surgeries can often be combined together, so you only have to basically go to the operating room once. So most people are familiar with eye drops of some kind, whether there's artificial tear or whatever it may be. But what we'll do is discuss kind of expectations about the lasers and the surgeries, things you may be less familiar with. So the SLT, this is that selective laser trabeculoplasty. Again, this is the one that is used for open angle glaucoma. It is painless. It takes about a minute per eye. There are no restrictions. We don't even dilate you. So you have your laser and we check your pressure about 30 minutes after, and you get to go home. Then we see you in a couple weeks, and then about eight weeks after that. The YAG laser is typically painless. I have had a couple of patients say that they can feel something in the eye, but it's not necessarily pain. Again, there's no real cutting procedure here, and so there are no restrictions. We tend to, for both of these, most physicians will give a mild anti-inflammatory drop for about a week to use to just keep down the inflammation in the eye. In terms of surgery, so most people on here, if you're over 55, you either have had cataract surgery or a family member that has, or you're kind of familiar with this, and so I bring that up because some of these minimally invasive glaucoma surgeries are a similar experience for the patient. They're typically either painless or minimal pain, just feels like an eyelash or a little piece of sand is in your eye for that day. Typically, it's gone by the next day. There are minimal restrictions, although there are some. With some of these procedures, we have you come off of blood thinners or any kind of aspirin or antiplatelet medicine, but some of those we don't even need to do that. There are a whole host of them, but basically some of the ones that are really gaining traction, we actually make an incision for open angle glaucoma, and we sort of open up that drain and let fluid flow more naturally, and those are really gaining popularity. And as longer term studies come out, basically it's showing that they have a nice long-term effect on lowering your pressure and helping reduce your need for drops. I contrast this to traditional glaucoma surgery. These are generally now kind of reserved for people who maybe have very advanced disease or need their pressure exceptionally low to help kind of slow the progress of their disease. These generally do have a longer recovery time. They can also, and this is one of the big issues is if there are things called glaucoma tubes and trabs, and they can require kind of some maintenance procedures down the road to help keep that fluid flowing and keep them open. And there's one thing that's kind of really important to note here is that unlike cataract surgery, these procedures are designed to prevent you from having further vision loss through lowering pressure. They do not improve your vision. And so a lot of people say, oh, this is going to return my vision. And it's like, well, no, it won't return your vision, but it'll keep you from hopefully losing more. Whereas cataract surgery can often be that instant gratification where the next day you're seeing better than when you started. So that's about 20 minutes. I did want to kind of keep this pretty brief and open it up to any questions. I found that typically people have lots of questions, and I'm happy to answer them as best as I can.
Thank you. I wanted to there's actually one question so far, but just wanted to open the floor for questions for anybody else. So feel free to open up that chat window where it says questions and then chat us questions. The first question is, I don't have high eye pressure, but doctors say I'm suspicious for glaucoma because I have large optic nerves. He has never suggested I see a specialist. Should I request to see one?
That's an excellent question. I'll kind of sort of go way back and it sounds like you're getting excellent care. And this is probably something I could have included. I was trying to keep it a little brief, but there are kind of three categories of patients, and this is how I describe this to patients when they come in. Is I say, hey, your optic nerves are suspicious, and what I mean by that is that you don't necessarily have glaucoma, but that I can't tell just by looking at you with a lens and my microscope whether you do or do not. And so what I do is I order one of those OCTs that I talked about, that color image, and that machine is exquisitely sensitive for early changes from glaucoma. And so that can be the machine that differentiates basically whether you do or don't. And the large cup to disc ratio, there are lots of people out there, and that's just how they're born, and that's normal for them. But then there are people that look exactly the same that do have glaucoma. And so differentiating that is, it can be a little tricky, but for most people, what I do is I say, hey, you're a glaucoma suspect. What that means is you do not have glaucoma, but we need to just do additional testing once a year to make sure that nothing sneaks up on us.
So what is the most common age you see patients report for glaucoma?
Just by the nature of eye care, outside of LASIK or PRK, most of our patients are in their probably late 40s up to early 90s. And I think I don't keep track of this, but just ballparking, I would say most of my patients with glaucoma are anywhere between the age of 60 and 75.
Can cataracts and glaucoma be treated at the same time?
They absolutely can. Those are some of my most gratifying surgeries. People that are on, 1, 2, 3, 4 eye drops a day, and they're just burdened by it. And not only is it a lot to keep up with, it's just this constant like keeping up with drops, and it's so many times a day. But once you get to that many medications that you put in your eye, it can actually, as somebody that treats a lot of corneal disease as well, it can basically cause chronic eye irritation, chronic eye redness, chronic blurred vision. It can cause the surface of the eye to just be pretty rough and kind of beat up from those medications. And so some of those patients that have cataracts, if we can take the cataract out and say do a procedure called a goniotomy, which is where we just open up that drain a few clock hours while we're in there, it adds an extra 2 to 3 minutes to your cataract surgery. I can usually get them off 1.5, 2.5 drops on average, and get them seeing better. And it's a really, really gratifying thing as a surgeon, because the patients tend to be so happy afterwards that they're able to use fewer drops.
Are there any surgical procedures that bring on glaucoma, maybe LASIK or PRK?
LASIK or PRK do not necessarily bring on glaucoma. The cases that we worry about with people who have LASIK or PRK are those who are prescribed long-term steroid eye drops to help them heal from those procedures. And so anytime I give somebody a steroid, I'm very, very careful to let them know that steroids can cause high eye pressure. And because of that, it's not something that you can perceive. And so because of that, I need to check you regularly to make sure that your pressures stay normal. And so, that's when I worry about LASIK and PRK causing glaucoma, not necessarily the procedure itself, but the medications we use to help you heal are steroids, and the steroids can absolutely cause that if unchecked.
Perfect. Well, I just wanted to, that looked like the last question, but I want to leave it open for one more minute here just to make sure that no one's sending any more in before we close out. So just wanted to give anybody else an opportunity here.
Excellent. Those are great questions. And if anybody, if you all, sitting up at night tonight thinking about this, wondering how I should have asked this, please call. I'm happy to chat anytime, and kind of just talk it over. A lot of these questions are they can be get fairly patient specific, but I'm happy to answer anything that I can.
All right. Well, thank you everyone for attending this evening. We appreciate it. The recording will be made available within the next day or two. So watch your inbox to have the recording. And we hope to see you in the practice sometime soon in the near future. Have a good evening, everyone.
Hey, thank you all. Appreciate it.